Hello, everyone, and welcome. My name is Daphne Watkins, and I am so pleased to welcome you to today's webinar. So today's webinar is sponsored by Core 3 of the Michigan Center for Diabetes Translational Research. Our Core 3, is the National Core on Community, Family, and Peer Support. And the core is a collaboration between the University of North Carolina at Chapel Hill, Ed Fisher and Pat Tang, and also the University of Michigan School of Social Work, Daphne Watkins, myself, and Jamie Abelson, who's also on the line. We are so excited about today's webinar because we have some pretty remarkable speakers who are going to talk to us, and I'm going to just jump right into things. So we're excited to welcome two of our colleagues from the University of North Carolina at Chapel Hill to give us a talk on development, testing, and implementation of the Med-South Lifestyle Program among adults with diabetes in North Carolina public health settings. So our first speaker will be Dr. Alice Ammerman. Dr. Ammerman is the Kaufman Distinguished Professor in the Department of Nutrition and the Director of the Center for Health Promotion and Disease Prevention at the University of North Carolina at Chapel Hill. She teaches courses in nutrition policy and public health entrepreneurship. She works with the UNC School of Medicine to improve medical training programs and uses social entrepreneurship as a sustainable approach to addressing public health concerns. So Dr. Ammerman is going to lay the historical foundation and context upon which we will have a second talk by Dr. Carmen Samuel-Hodge. So Dr. Samuel-Hodge is an associate professor in the Department of Nutrition at the University of North Carolina Gilling School of Global Public Health, the Evaluation Core Director at the UNC Center for Health Promotion and Disease Prevention, an adjunct assistant professor at Duke University School of Medicine, and embedded faculty at Granville Vance Public Health, which is a rural academic health department. Dr. Samuel-Hodge's research targets chronic diseases that disproportionately affect African Americans and other racial ethnic minority populations. So please join me as we first welcome Dr. Ammerman.
Hello, everybody. Am I sharing my slides effectively yet?
Yes, we can
working?
see your.
Okay, the hardest part of academia these days. Thank you for inviting us. Always happy to be working with Carmen because we continue our collaboration of many years, and happy to be with this group. I thought it might be fun to start with this slide. Where in the world is Ed Fisher? So he just sent us this picture this morning, actually, and you can see that he's practicing the Mediterranean diet as we speak. And so we'll call this the Med-Southern France diet. So it all started a long time ago in terms of the Mid-South diet, with a dissertation being mine and a fellowship being my husband's, trying to reduce heart disease risk in a southern rural low-income minority population in an economically distressed county. He was doing Robert Wood Johnson Clinical Scholars Program, and I don't know if you can see my arrow, but I was commuting back and forth here, 72 miles each way to do my doctoral training. So our challenge was the very high rates of heart disease in this county, not much in the way of options for health promotions, recognizing physicians see patients about 4 times a year, but they have often very limited training or experience with nutrition or lifestyle counseling, and the visits are often overwhelmed with other things that they need to address. So I like to use this slide from Russ Glasgow about the importance of implementing things that are feasible and usable in the field. So if an intervention works and nobody uses it, does it still make an impact? So thanks to Russ for that. So the opportunity was to try to create a tool for provider counseling that makes it quick and easy to assess diet, and provides kind of foolproof counseling tips, so you don't really have to know a lot about nutrition if you follow the toolkit. Make it culturally relevant for the patient and use key behavior change strategies. So as you'll hear a lot more from Carmen, many years later, in terms of overall reach and impact, and my numbers probably need updating now, but We've tried it in 30 plus community health centers, many FQHCs, 50 plus health departments. It's been delivered by physicians, health educators, nurses, CHWs, phone counselors. We've kept it updated with the evolving scientific evidence. We've gone from the low fat era to the good quality, higher fat era. Big improvements in diet and physical activity have been reported from a number of our studies. Also improved blood pressure, cholesterol, BMI, and carotenoids in some cases. So these are the humble beginnings. And I actually drew these pictures myself back in the old days for my dissertation. Not very good, very old school, but now we obviously have much better options. And here again, these are practically yellowed pages here, but we use this column system, which we actually still use, to a way of assessing quickly and being able to read, again, without knowing a lot about nutrition, as to what could be improved. And one big project we worked on was the Wise Woman study with the kind of an offshoot of breast and cervical cancer control program. CDC came to us and said, how can we help states really understand what are the core pieces of intervention, kind of back to the Russ Glasgow thing. What do they really need to do in order to make a difference? We ended up adapting it for multiple states and adding it to Spanish translation. And then we expanded it to include physical activity, healthy weight, smoking, and quitting, diabetes, bone health, and some people used to tease us. We called it the new leaf intervention. Some people said you should call it the get a life intervention if you're going to change all these things at one time. We've done a couple of validations of dietary risk assessments as the dietary recommendations have changed, and we found ways to streamline more. This is still old, but it's much nicer than what I showed you initially, and Carmen will show you the much newer version, but it's still using this assessment and a coordinated counseling. And then, as Carmen will show you, she branched out into many different areas, and we'll talk a lot more about the diabetes focus. Even, I don't know if you were going to talk about this, Carmen, but she even worked with the Rochester Prevention Research Center to adapt it for American Sign Language to use with the deaf population, which is quite an achievement. Then the next big thing we did was the Heart Healthy Lenore project. This was part of a National Centers for Population Health and Health Disparities. And see, we were here, one of the 10, there were 5 that focused on cancer and 5 on heart disease, and we collaborated with a county in Eastern North Carolina. This was, I served as co-PI with Cam Patterson, who's in cardiology, and we had a visit from Francis Collins. They asked us to show the interdisciplinary nature of our research. And so I thought it would be fun to do this if you look at the very different approaches, but then when it comes to cabbage, because he was a cardiologist, and so Francis Collins, who was the head of NIH at the time, gave me a good laugh. So that's one of my cherished memories. And in this RFA, amazingly enough, now it's stated all the time, but it said must use community-based participatory research methods or it will be returned as non-responsive. So this was kind of one of the early ones really emphasizing that. And Lenore County is in what we refer to as the stroke belt in Eastern North Carolina, with much higher rates of cardiovascular disease. So very much an important place to try a cardiovascular health intervention. We had a really large and important community advisory committee that met regularly, offered project guidance, represented many different groups, as you see here. And one big thing they helped us navigate, which we could talk about more later, was the complicated situation of returning genetic results. This was way before that was very common, and we were measuring some of the genetic results, but we had not initially planned to return them. We eventually did after the advice of the Community Advisory Committee. In terms of conclusions from all this, and I could go on many slides, but just a quick summary. And dietary, we saw important improvement at 6 months that was sustained at 24 months. Initial improvement of physical activity, but then it largely went back to baseline, unfortunately. Blood pressure, which was our primary outcome, we showed improvement at both levels, and then some modest weight loss. And this is a publication with some of the main results there. And then enter the Med-South Lifestyle Program. This is now a dated slide as well. You'll see the really beautiful ones now that Carmen has been working on. And this kind of stemmed from this Heart Healthy Lenore project where we were adapting the Mediterranean diet, but hadn't really come up with this name. But we find that it's important for people to understand that the principles of the Mediterranean diet can really be adapted to almost any culture, and it doesn't mean you have to eat grape leaves and olives all the time. Because people have written about this, and like in this article, the whiteness of the Mediterranean diet. And I would say that there's some confusion here in thinking that you, again, have to eat like the Mediterranean in order to have a Mediterranean diet. So people have had fun with the Med-South diet. This is a publication on our campus, and because you'll see that we've adapted hush puppies for the Mediterranean diet. So they thought the headline would be good of hush puppies on a diet. So we got started with this at Kinston, which is in Lenore County, at their barbecue festival. We decided we would see if we could participate in that. So I put together just a bunch of Southern vegetables, and usually I quiz people when I'm giving a talk where I can see people as to what happens to barbecue as you move, or barbecue sauce as you move further east, both in the country and the state. And the answer is that it becomes more vinegar based. And a lot of people in North Carolina put vinegar on their vegetables, so I didn't think it was too big a stretch to use barbecue sauce. Or vinegar-based sauce. So this was the festival. This is the real barbecue line, and this is our little booth here. Much shorter line, but it did give us an opportunity to work the line with free samples. But you can see their expression here when I said, "Would you like to try some heart healthy barbecue?" Most people were skeptical, but others said things like this, that they really enjoyed it and they would make adaptations. And this guy the next year gave us a thumbs up as well. And we did some surveys, and most people were willing to try it again. A little skeptical about whether their families would like it, but overall, good findings. So having mastered barbecue, I decided to take on hush puppies, using more whole grains and then chopping up nuts and vegetables as the Mediterranean diet would recommend, cooking them in good oil, mostly olive oil, and then of course serving them in the context of a healthy meal. So just kind of showing you that you can adapt a lot of things culturally. And then just taking it one step further, beyond the US, I was asked by some colleagues working in Nairobi, Kenya, where the concern is growing about chronic disease rates there, unfortunately, largely because us shipping over ultra processed foods, that kind of thing. And so we actually kind of wrote up the basics of what a Mediterranean Kenya diet would look like. And one of the things that it's not a huge improvement in nutrition, but everybody talks about these fried dough balls that people sell on the streets. And so I just suggested that they could include fruit like mangoes and use a little less sugar. And as long as they use good oil, it's not as bad as maybe they thought. So then, while Carmen was going deeper into more of the public health clinical kind of part of things, I decided to go towards a food system and entrepreneurship approach. So we created a product called Good Bowls that are based on the Mediterranean diet. So this is based on the bigger problem of food insecurity and lack of economic opportunity in rural North Carolina. Long history of discrimination against Black farmers, lack of access to healthy food, rural poverty, high rates of chronic disease, and then food waste is increasingly a concern, with the 35 to 40% of food being wasted in the US. So this is an attempt to hit more at this bottom part of the food of the pyramid that Tom Frieden put together, where up here you see we spend a lot of our time up here, but there's less population impact and more individual effort needed. So, obviously if we could get rid of poverty, that would make a huge difference. But if we can have some impact on rural economic development, that's another benefit. So I actually created a company that we call Equity Foods that makes and markets the Good Bowls. They're locally sourced, healthy frozen meals. So we use the Mediterranean Mid-South diet to guide the contents. We work a lot with community organizations to make food available for those who are food insecure. And then we source locally to support local farmers. And we try to use grade B, which is the cosmetically challenged food, since we can chop it up and cook it. So I am required to make a disclosure that I'm the founder of Equity Foods. I have gotten rid of all equity in equity. Little irony there. I'm now a volunteer advisor. So this means that the university does not worry about conflict of interest. So I can use it for my research, and I'm doing quite a bit with that now. And one of the ways we've used this is for what you may have heard about 1115 waivers, which we call the Medicaid transformation as opposed to expansion, although thankfully North Carolina has expanded Medicaid as well. And this is kind of a food as medicine approach. It allows Medicaid dollars to be spent on social determinants of health, one of which is food insecurity. And so we provide boxes of these healthy frozen meals to people who are referred from the program. And then like another example of programs we're working with is a group in Raleigh. They call it Wake, Heat, and Eat. I'm not going to show the video here, but I'm happy to share that later. So these are counselors who work with people who have severe mental disabilities, and they take the meals with them as kind of an entree to kind of create more trust and provide some immediate benefit to the participants. The key to this solution is to almost all the work we do certainly is partnerships with, in our case, local farmers, businesses, nonprofits. Let's add a few more here. And then on the research side, I started the company as a for-profit because that's required in order to get funding for small business innovation research. So we have funding from NIMHD for a project we call Good Bowls, Empowering Communities to Achieve Good Food Access and Health Equity. We are now in a phase 2 stage, and we're testing this in workplace settings. We call it Eat Well at Work. This is a very rural manufacturing plant, and this is the only food that's available to 160 workers with a meal cost of about $7.50. We tested the Good Bowls there, selling them for $4.50, and people were interested in trying them. And we're now working with the transportation and public works folks in Chapel Hill, and they have the same kind of setup. This is the only food that's available to them. So we're trying to test to see if we can make an impact by having healthier options more readily available, and at this point, subsidizing the costs. And then just quickly circling back, since we started out with a tool for physicians, I have a doctoral student, Caitlin Hildebrand, who has an MD and MPH, and decided, I tease her that she saw the light. After medical school, she decided she wanted to do nutrition and said, being married to a doctor, I can make doctor jokes like that. She and or we, you'll see Carmen's in here, and this is my husband, Tom Kaiserling. We published this in the medical clinics of North America. They asked us to write a whole chapter about how physicians could do more to reduce chronic risk. And just a couple of days ago, Caitlin had published her scoping review of culinary medicine for medical training, and we're doing quite a bit of work with that now. And she has circled back, and we're taking what we call starting the conversation, a tool for physicians to use to do very quick counseling and trying to spiff it up a little, make it look a little better and be easier to use. So because it's a trifold, the numbers seem odd, but this starts with, so it's just a few quick questions about assessment. So challenges and opportunities. It's funny because this was a slide from years ago from that set that I pulled out, and it still applies. It's got to work for both the patient and the provider. Carmen's going to talk a lot about how it's important for dissemination and implementation to make it work within the settings that are delivering the intervention. understanding the context is key. Again, the D&I science. Keeping up with ever-changing literature on diet and health poses challenges and opportunities. It takes a while sometimes for the population to come around to the fact that we're no longer suggesting low-fat diets, and how could fat possibly be good? So healthcare delivery systems are also ever evolving, and I will just add that keeping a sense of humor, as in all things, is important. And let's see, I think we were going to have a few questions now. Is that right?
Yes, that is correct. And so we have time to pause here and take a couple of questions from the audience.
No, that was rapid speak. I guess I made it in time. Huh?
Yeah. And Pat, you may be able to see the questions better than I can. Actually, I can't see the audience questions, so you'll have to let me know.
Yeah. Yeah, I'll let you know. We don't have any in the Q&A right now. But people feel free to unmute yourselves or, raise your hands if you'd like to ask a question directly to Alice.
I have a question. This is
Hey, sure you
hi to
can.
both of you, right? I wanted to know more about how you all had developed this Mid-South diet. So this is a great opportunity. I was just wondering about the business end of things. Alice, you described it as very, very fluid way, but I thought about where do you get the technical assistance to make frozen meals? How does that work in a place? Like, how do people thaw them out? I mean, there are a lot of details that the average researcher wouldn't be able to command.
Mm-hmm. Yes, I've learned a lot. For the most part, we're working with our local co-op, the Weaver Street Market. They have what they call the food house, where they produce all of their prepared meals. And so they are skilled doing it. Although hadn't done that much with frozen before we worked with them. Interestingly, a student whose co-founder took my course, he founded a company freezing vegetables just straight up. Now has gone national and is very successful. And now he's serving as a board member on a nonprofit that we're starting as kind of a parallel hybrid with the for-profit, because even though I had to start as a for-profit to be able to get these small business grants, there are a lot of funding opportunities that are only available to nonprofits. Now, part of my initial thinking was hoping to get off grant dependency at some point. We're not there yet, for sure, but trying to make something more sustainable so that we could, not just have to keep getting grants and grants. And with the food as medicine efforts going on and these reimbursement strategies, it's making it much more possible. And insurance companies are now starting to include food benefits as well. So timing is good in that respect. We do much better with these reimbursable programs than we do the markups. It's kind of a brutal thing world out there with frozen food. They mark it up 40%, and you're already paying more for to try to give the farmers a fair shake and also keep the price affordable. It's very hard to balance that.
Thank you.
Mm-hmm.
Right.
Professor Ammerman, we have a question in the chat as well from Talia. What is the role, if any, of social workers in this program?
Well, I always think social workers are among the most important profession. Community health workers, I think, sometimes have at least background and training in that. I mean, the people who make the referrals to this Medicaid program are often trained in social work. They're health care managers who are part of a health department or clinical team. So I think a very important role in a lot of different domains. I don't know, Carmen, do you want to add anything to that?
No, I agree. The case managers at the health department tend to have backgrounds in social work. Mm-hmm. They're the ones who connect patients to resources.
Mm-hmm.
Yeah, sorry, I was the one who asked the question. Thank you so much for the answer. I think then where I was coming from that one is that I'm enrolled in the School of Social Work at Michigan, and you had started the the session talking about, counseling, and I wasn't sure if there's some sort of kind of end-to-end process that they go through where they, work with both a nutrition counselor as well as like a social worker. Since I know you did, and I appreciate this, you kind of emphasized that this program is very much kind of a lifestyle change rather than just basically like a point solution. So that's where that question came from. I'm not sure if there's anything else that you wanted to add given that context I just gave.
Well, one thing to add is in a clinical setting, social workers are often key to planning for when patients are discharged and go back into the community, and making sure that they're connected with SNAP and WIC and programs like that, that usually the physician wouldn't be familiar with, or sometimes register, the RDs in a clinical setting may know less about community resources. I think that's another thing.
Got it. Yep. Thank you.
I can add something here. In our last study, one of the things we did, because we were targeting rural communities and communities where there were high levels of poverty, and here we are, recommending a dietary pattern with increased fruits and vegetables, etc. One of the things we did was we created what we call our resource manual, which included all the local resources dealing with food, medication adherence, physical activity, and we provided a county level resource manual that went along with our program, so that for people who didn't have, for example, enough access to fruits and vegetables, we identified for them where in the community they could find it. And that seemed to work well with our program, where community health workers were the ones who delivered it, MedSouth. So
it's really interesting. Yeah, thank you.
All right. I think with that, we can go ahead and transition to our next presentation.
Okay. All right. Can you see my screen?
Yes.
Okay. All right, so Alice has set you up well by describing exactly what MedSouth is. And what I'm going to do today is walk you through a little bit about the implementation type research and some diabetes specific research that we've done that builds on this MedSouth program content. Whoa. There we go. So here's how the next 20 or so minutes will unfold. I'm going to focus on the community engaged and implementation research conducted more recently in public health settings, where our study population has included large proportions of adults living with diabetes. Then I will briefly describe a family-centered weight loss intervention for African American adults with diabetes, paired with a family member at risk for diabetes. I've included this study because it serves as the preliminary research for a new grant we received. Yes, Shariki, we got it yesterday, and that I will describe very briefly. The other research, new research, is focused on diabetes self-management education and support, or DSMES. And in that new research project, we're specifically targeting rural residents and those who self-identify as African American or Black, American Indian, or Hispanic Americans. So this is our implementation research study. It's called Change, and this one was, this is CDC funded. Change stands for Carolina Heart Alliance Networking for Greater Equity, and it was conducted between 2014 and 2019, and evaluated, and here we evaluated the implementation and effectiveness of the MedSouth program using a, what they call a type 3 hybrid implementation effectiveness design. And then we had a single arm pre-post test study design for effectiveness outcomes. In this type of hybrid design, the primary research question is to determine the impact of an implementation strategy with a secondary aim of assessing clinical outcomes associated with implementation. So type 3 designs are used in implementation studies when the concern is that the concern is about the intervention not being delivered as designed in real world settings. This 3-phase study included an initial community engagement phase where key community leaders and organizations came together to decide on adaptations of the Med-South program that would be needed to fit the rural residents of a county with a majority African American or Black population and also high rates of poverty. The second phase was the feasibility study in one federally qualified health center and a local health department. And then the third phase of change involved a larger implementation study in another county with another FQHC and local health department pair. So the references for the 3 phases of the study are on the slide, and you can, get the details there. So cardiovascular disease risk reduction interventions delivered by community health workers are recommended by the Community Preventive Services Task Force, but very few studies have included rural, racial, and ethnically diverse populations. And this was one of the main reasons for choosing community health workers to deliver the Med-South program in this study. Combining the samples from the feasibility and the larger main study, we conducted the change study in rural counties with about 87% of adults self-describing as non-Hispanic Black, mostly women, and participants had a mean age of 60 years, or about 60 years. 32 to 55% of the study samples lived with diabetes and 81% of them with hypertension. So because CHWs were selected for program delivery and counseling visits were in the participant's home, so this was a home visit delivered Med-South program, or participants could identify a community location where they wanted to meet with the CHW. Because of that format of delivery, we limited the study measures to include only weight and blood pressure, which would be taken by the CHW. The staff at the Center for Health Promotion and Disease Prevention administer the pre and post program surveys to assess diet and physical activity behavior changes. And then in terms of our implementation measures, we targeted delivery fidelity, participant reach, and participant retention. All right, so these are the results from the combined feasibility and main study. And again, this is 4 sites, 2 federally qualified health centers and 2 local health departments in 2 rural counties. So in terms of our implementation outcomes, which is not on the slide, but I'll just talk you through them. We found in the main study, participants completed 90% of the planned intervention contacts, and 87% of them remained in the program all the way to the end. In the feasibility study, however, it was just 80% of the planned visits completed, and then retention was 72%. So we learned a lot from the feasibility phase, applied that, and had good outcomes in our main implementation study. In terms of intervention delivery fidelity, we found that participants received a mean of 3.5 of the 4 counseling visits and 2.7 on average of the 3 booster calls. So good uptake. And the study reached a larger population of adults self-describing as African Americans or Black than that of the county's population of African Americans. So we were glad that we were able to reach populations with high need. Our program effectiveness outcomes are presented on the slide. And then it's not mentioned here, but all of these changes are statistically significant. We saw almost a 1 serving increase in fruits and vegetable intake, sugar sweetened beverage consumption was lowered, and the intake of nuts increased. Self-reported physical activity increased by 43 minutes per week, and reductions in both systolic and diastolic blood pressure were observed. All right, So that's our, 5-year, 3-phase implementation research project that really looked at what do you get when community health workers deliver the Med-South program to rural residents with in settings where there's a high degree of poverty. So I'm going to transition now to a diabetes specific study. We conducted actually this is my KO1 research that was published in 2017. The study is Family PALS in Lifestyle Support, or PALS. And I'll talk to you a little bit through the design and testing of this study, only because it becomes a preliminary study for a grant we recently received. So Family PALS was in randomized controlled trials testing a family-centered intervention. And this study may still be the only published family-centered weight loss intervention among adult African Americans with type 2 diabetes and an adult family member. And in general, there are very few family-centered weight loss interventions conducted among African American adults. Shariki is in the audience, and she conducted one of them with family and friends. That study was called SHARE. And then another colleague at UNC did a family-centered weight loss intervention with African American couples. So there are not many studies out there, even though we recognize that family context is important to lifestyle behavior changes. So within the African American culture, the extended family outside the household with whom there is regular contact also represents an important part of this family context. So not only the folks in the home, but those who family members engage with, families living with diabetes engage with. So that's who we're considering family. So in Family PALS, family members were eligible to be partners of the index person, which is a person with diabetes, if they did not have a diagnosis of diabetes and lived with or were married for at least a year to the index person, or were self-described blood relatives who had regular ongoing contact with the index participant. And they did not have to live in the same home. In terms of eligibility, we selected adults 21 to 75 years of age with type 2 diabetes for the index person and a BMI between 25 and 47 inclusive. And we just made sure that their A1C was less than 11%. Those were pretty much our inclusion criteria. So this study included 54 dyads. They were mostly women, and 29% of the dyads included a spouse, and 37% lived in the same household. So you can see here, the dyads included people who didn't necessarily live in the same home. The weight loss intervention included 20 weekly sessions, and these were delivered in person and in group format. To get to the place where we had an intervention, a lot of formative research took place. We included qualitative research using focus groups with family members and persons living with diabetes. And that was really to figure out what content needed to be added to standard behavioral weight loss interventions to address a family context, a family-centered approach. And in doing so, we were able to use that information along with qualitative findings to develop 10 what we call family time segments that were added to the weight loss behavioral sessions. And key intervention components in these family time segments focused on family communication, family conflict and support, and skill building in problem solving and coping. On the quantitative side, we had to look at the measures of family functioning and make sure that they were validated in a sample of African Americans. And so we did that validation testing. And we also did that, and we also had to figure out which of these constructs are most important to a weight loss outcome. Once all of that was done, we then brought in a clinical psychologist who took these qualitative findings and created the program content using cognitive behavioral strategies to address, thoughts, feelings, behaviors, that sort of thing. So a lot of work went into figuring out how do we adapt standard behavioral intervention, weight loss interventions for a family-centered approach among African American adults. And so these were the adaptations we made. As I mentioned before, we defined family really broadly, as we should for cultural reasons. And one of the things you find with family-centered interventions is that oftentimes they don't measure the outcomes for the family members. And so we made sure that we did that. And then, oops, sorry. And I think a big part of this is to make sure that what I wanted to demonstrate was that the same standard behavioral weight loss that we promote in programs like the diabetes prevention program, if you add a person who has diabetes to that, both people benefit, and they'll likely benefit more because they're doing it together. And so this study was to really demonstrate that that could be a positive outcome for this particular subpopulation group. So in terms of the cognitive and behavioral skills, as I mentioned before, we focused on cohesion, communication, conflict, social support, problem solving, and coping. All right, so these are our outcomes for Family Pals, and you can see we were able to see about a 3.62 weight loss in the index person. This is a person with diabetes. And I can tell you now, it's really hard for people with diabetes to lose weight, especially in behavioral lifestyle interventions. We were able to see that 42% of the sample lost at least 5% of their weight and initial weight. And for the family members, we also saw, decent weight loss outcomes. What's also important here is that among the index participants, we found A1C improved significantly, depressive symptoms improved, family interactions improved, diabetes self-care, diet, and physical activity behaviors all improved. And what was most interesting is we found, and I think Sharika, you found similar findings in your study, that the paired attendance, when the diets came to the sessions together, they lost more weight. And so that also is an encouraging finding, to the extent that we're really talking about social interdependence here, where people are cooperating to work together on a goal. So those two studies I described, Change and then Family Pals, will serve as the basis for the new research that's going to happen in the next couple of years, starting this year. And so the new research that we have include adding social network analysis to the same family-centered weight loss intervention I just described. And then the second one will add system science methodology to a diabetes self-management implementation study. So in both cases, we're adding new elements that will allow us to better identify what specifically is happening and how can we make changes or adaptations that would allow for better outcomes, because we're specifically targeting these populations at higher risk. And so, as I mentioned earlier, we found out we were awarded this study yesterday. And the study is called Family-Centered Weight Loss for Black Adults, Optimization and Evaluation Using a MOST Design and Social Network Analysis. So this is NHLBI funded. It builds on two family-centered weight loss studies that our group at UNC has completed. And we have the wonderful task of recruiting 256 dyads, so pray for us. It will be a challenge. And the two things that are new here is that we're using that MOST design, which is really an effort to move away from that kitchen sink approach to multi-component interventions. And then another emergent strategy, which is to really, instead of looking at the individual for individual level chronic disease management, we're looking at the social network around that person to really leverage that to promote better chronic disease management and lifestyle behavior changes. So those are the new elements in this particular study. So here are two of our aims on the slide. Number one, this study is to figure out what's the optimal combination of components to put into a family-centered weight loss intervention. And you can see the 4 components we're looking at is looking at the training session quantity. So in Family Pals, we had 10. In another study, we had 5. So which is it? Which one gives you the optimal outcomes? Then the other one is looking at delivery mode, online versus in person. And then the other components are really about, so what will give us the better, the higher bang for a buck? Is it really training and communication and conflict, or is it building cohesion? And you can see here you have essentially 16 experimental conditions with those 4 components being on or off or yes or no. And that's essentially the optimization part of it. And then we will use SNA to find out who within the person's social network is influencing either positive or negative behaviors related to weight loss. And we're measuring not only family or kin, but we're measuring family and non-kin network actors. So we have experts on these 2 elements, which is what I'm excited about learning, both the MOST design as well as SNA. And then our next and last study is new study is really looking at implementation focused on diabetes self-management, education, and support in public health settings. So this is the new CDC funding for PRCs. And what they wanted us to do was to start with an evidence-based intervention or policy and implement it in real-world settings. So we chose the SMES as our evidence-based intervention. And just to give you some context, North Carolina is one of the southeastern US states included in the stroke belt and the diabetes belt. All those blue counties that you see on the screen are counties in North Carolina with a diabetes prevalence greater than 11%. And so many of them are in the belt. And what we know is that, and you can see here the yellow dot pyramids, triangles are counties where there is a DSMES site or program. And you can see there are a number of blue counties there that don't have a yellow dot in them. So there are a number of, and especially the rural counties, they tend to not have as many DSMES services as would make sense given the prevalence of diabetes. And just to give you the context for DSMES, nationally, only 5% of newly diagnosed Medicaid beneficiaries take advantage of DSMES services, and only 6.8% of private insurance beneficiaries actually take advantage of using DSMES services. So it's really underutilized. And then with rural settings, they have even less access to DSMES, and even when it's there, they don't use it. So it's an issue. Here you have an evidence-based intervention that's not being used. So we are going to focus on the underutilization of DSMES in rural counties. We'll focus on 3 high-risk population subgroups, which include African Americans, American Indians, and Hispanic Americans. And the innovative part here is we're using system science to help us identify the barriers and facilitators to DSMES and then use that information to figure out what our leverage points are and how we can improve the system for these 3 population subgroups. And that will allow us to adapt our approaches to DSMES so that we can then see what the difference is in terms of outcomes for these 3 population subgroups. The MedSouth program will be included in this in the sense that it will become the dietary component of DSMES. And we need to make sure that that is also adapted for these 3 particular populations. So our initial phase, we will do the system science evaluation of barriers and facilitators. And then in phase 2, we will do the implementation study, which is again a hybrid implementation effectiveness study. And in phase 3, it's dissemination. So this is my last slide here. And this just shows you what our phase 1 aims are in our phase 2. And you can see in our phase 2, we are proposing to recruit 12 sites, health departments and FQHCs, and then randomly assign sites to either a tailored, which will include the MedSouth dietary recommendations versus standard DSMES. And our partner in this is the state level ADA recognized umbrella DSMES program. So these are just 2 of the new studies that build on the research that we've done that all pretty much include either the MedSouth program as a program itself or the recommendations from it. And that's it for me.
Thank
Any
you for that.
questions? Oh, you're welcome.
Thank you both for your fantastic presentations. I think what I want to do is first see if there are any questions for Dr. Samuel-Hodge first, and then we'll open it up and take questions for both presenters.
I had a question around just engagement for dyads. I'm doing a pilot right now with dyads, but in a older adult population where one person has cognitive impairment.
Oh.
And I wondered if you encountered any surprises in your work early on. For me, I discovered that I thought family members would be able to make it to culinary workshops for management of diabetes, and it turned out they're bringing their home attendants. So we've had to pivot and think about that. That certainly has a value and an impact, but it completely changed the dynamic and the approach that I was thinking of. So I'm wondering if you encountered similar issues.
Yeah, one of the things when we did all those focus groups, really talking to family members who had a family member living with diabetes, we kind of heard a lot of stories about who was engaging with whom for what in terms of diabetes self-management. And so that information was important for us to figure out how should we organize our eligibility criteria for being a part of the dyad. And so it wasn't just any old family member, it was one who was engaged with you in your diabetes care. And so that made it easier for the person to figure out who that person was and then bring them into this study because they were already engaged with that person. Does that make sense?
Yeah. It sounds like a lot of the pre-work is helpful to kind of hone in and focus your design.
Because not all family members are helpful. So you have to really they're not. And so it's a matter of really having that person think about who are the people who help you with this chronic condition. And also in our case, we're interested in losing weight. Would you come into this program paired up together?
Okay.
Yeah.
Thank you.
Happy to take other questions for Dr. Samuel-Hodge before we open up the Q&A for both presenters.
Okay.
So I see one question in the chat that I'm assuming is for you, Dr. Samuel-Hodge. It says, did you or do you plan to use any specific implementation frameworks?
Oh boy, yes. So there's a colleague on our team who is an implementation scientist, and much of what we do is based on the, everybody, Consolidated Framework for Implementation Research, CFIR. I guess there's a new version of it that's hopefully more useful than. And then, of course, there's the strategies that are informed by Powell and Eric. So those are expert recommendations, I guess, for implementation research. So those are the two that come to mind in terms of the framing for implementation research. Does that answer your question? Whoever that was.
We received a yes, that answered.
Okay. Yeah.
Yes. Okay. I'll just pause for another 10 seconds to see if there is one more question for Dr. Samuel-Hodge, and then we will open it up.
While you're waiting for the next question, one of the things that I think I should mention this because it is a thing right now. We now have anti-obesity medications. So people are like, so what do we do with these behavioral interventions? Do we throw them out the door? Are they needed anymore? And, one of the things where, there are a couple of things to keep in mind. Our population is African American, and that population, there's a level of trust or mistrust in terms of medications, and a lot of, for example, your GLPs. Yes, it's a drug that will get you your 20 to 35% weight loss, but it's delivered by injection. And so a lot of people with diabetes don't necessarily want another injection. And so that's an issue. There's a cost issue in terms of, even if you're covered by insurance, the copays are pretty high for the drugs. And there's some resistance to using them. Some of that has to do with the GI side effects. But all that to say, as we figure out how to include these AOMs into weight loss treatment, there's still a place for behavioral weight loss interventions. And actually, the studies have shown if you start off with them and then you add the medications afterwards, you end up with better outcomes. So a sequential approach is probably going to be better than having folks start with those and not really have any idea of how to manage the diet and physical activity components of weight loss treatment. We had to answer that question for a project officer to argue for our study. So, and the other thing to consider there too is that while the drugs are designed for people with diabetes, there are a lot of people who don't have diabetes who want to use them, and they're insured. And North Carolina has decided that they will not, on the state health plan, which a lot of people are on, they will not pay for obesity medications for those who don't have diabetes. So that's also an issue to consider.
Yeah. Well, we have another question that's come in.
Okay.
So with the dyads, did you notice any new ties created from the index participant? In other words, did any of the index participants shift their role and start to influence others in their networks?
Okay, one of the things we did as part of Family Pals was we really had folks to figure out what their role was. And if it was a role that was one that also had conflict in it, we helped them to figure out how to change that, how to modify that with some of the trainings that we had. And so some roles shifted because some of the roles shouldn't have been roles for them to begin with. And so they shifted. But one of the things that's important in group-based interventions is that you end up getting also support from the group itself. And that happened with Family Pals. Not just your dyad, but the other dyads in the group became groups. So that, it's helpful. You take all the support you can get, especially for, a weight loss outcome.
Absolutely.
Yeah.
So we're going to open it up now and have questions and answers for both of our presenters. And so one question that came in earlier, Dr. Ammerman, was, do most hospitals or clinics know which patients have food benefits?
Yeah, I saw that question. The EPIC, the system which most hospitals are using now does have questions about food insecurity. I'm not sure if they ask about programs that people are on, but the problem is many people don't ask for it. They have to think about it. So probably is not automatically available, but I would think certainly a social worker would probably ask about that for discharge planning.
Thank you for that.
Hmm.
And we invite others to ask questions or to share in comments for our two presenters as well. So feel free to unmute your microphones, or if you're in a noisy place, feel free to type right into the chat where your questions are, and we'll hold space for you.
Yeah, I have another question. I think it's
Please.
for both of you. You mentioned community health workers delivering this intervention, and it sounds very easy when you say it, but there must be a lot that goes on to get the quality that you want of implementation. And so I just wondered if you could talk a little bit about that, and if some of the community health workers also have diabetes, and that becomes a part of it.
Mm-hmm. So one of the things we do in training any of our counselors to deliver Med-South is to really focus on, to de-emphasize teaching, because we do so much teaching, and adults don't need to be taught. They just need to have conversations with a counselor that helps them figure out how do they address this problem that they find to be important. So in our trainings, we cover adult learning principles, motivational interviewing principles. We cover ways to have a conversation with someone about changing a behavior, not about drilling them with information. Information is a part of it, but there's a way to share information that builds on what does the person know already, what's important for them to add to their knowledge base, and then, engage them in the problem solving and the goal setting and all of that. So I always tell my in the training for the counselors is, you are building a relationship with another adult learner, and how you engage with that person will determine the outcome. The information is in Med-South is written at a 5th to 6th grade level, so it's quite readable when you think that a lot of health information is not at that level. And so you have the written information that's in a conversational tone and low reading level, for low literacy participants. But the real thing is the engagement with another human being who actually cares whether you get well or not. And I think that's what we train on, the engagement part of it, not the education. Because I think sometimes that's disrespectful to adults, because you kind of treat them like children, and they're not. And so we really focus on starting out with, how will you engage with this other human being around changing a behavior that they said was important for them to change. That's what we do in terms of training.
Sometimes I describe the tool that gives you the easy assessment and then link to the counseling of the behavioral tools that Carmen's talking about, that it's kind of equally useful for physicians and community health workers, because both of them have a lot of credibility with the people they're working with, and neither of them tend to be well trained in nutrition. So it allows, it helps them do the assessment, and then it's very easy to see what the recommendation would be.
And the other piece is, I think oftentimes we have community health worker delivered interventions, and they're put out there on their own, and there's no support staff for them in the background. And we always made sure that if they had questions when they were doing their counseling visits, they could bring them back to us, and we would provide them with, responses that then they can go back and give to the participants. So again, like Alice was saying, we developed this such that you don't need a high level of knowledge of nutrition. You just need to know how to engage with another human being, and the resources are there for you should you have a question.
Mhm.
Yeah.
I can answer the chef question if that was in the chat, if you don't have another one waiting.
Yeah.
So,
For it.
well, I love to cook, and I've experimented on my children and others for a long time. So, most people seem to think my food's pretty good. And then others who work with us also, it turns out, like to cook, and we're probably drawn to that. And then, so we tend to kind of have recipe testing parties and adapt them with each other. And then we work with the executive chef at the place where they're actually produced to kind of fine tune them. So, because we really are trying to strike a balance between what people are used to eating, like chicken burrito is like one of the favorite recipes. It's not fancy, we're not doing tofu and bean sprouts. We're trying to find things that people can relate to. So sometimes if you go to a fancy chef, they're going to involve all these expensive and maybe not so appealing food for people. So it's striking that balance.
Thank you very much. That sounds great. And I'm going to start doing tastings with my group. And we can do some potlucks and see what we can come up with.
Good.
That's really important. Yeah.
And it's fun, you have to have a thick skin, because people don't always like your recipes.
No, give people the permission to not like it, and it always works.
The other day when I was visiting Robeson County, which is one of the counties that has the worst health statistics, it has a large Native American population, and I learned about a dish called chicken bog, and everybody was so excited about it. And it turns out it's just rice and then chicken, and then usually some sausage. So I came home and made some, but I had brown rice that I used, and I snuck in a bunch of vegetables. So, I haven't had a chance to test it with people accustomed to the traditional chicken bog, but usually there's things you can do pretty quickly to a recipe and keep some of the things that people really like, and then do a little stealth health, as we say, slip in the vegetables.
Yeah. One of the things we find from participants who are in the Med-South program is that the thing that they said, they felt comfortable with the program because, again, it was familiar to them, and it didn't make eating healthy seem as if it was unattainable at their level of income or resources. And so that piece of it, I think, is one of the reasons it works well in the settings that we've tested it in.
One of our favorite compliments is when people say it doesn't even taste healthy. Kind of a sad commentary, but you get the gist.
Yes, I see a hand. Hello, Sella. We welcome your question or comment.
Thank you. To my camera. I'm sorry.
That's okay.
There we go. Hello again, and thank you so much for an insightful and certainly thought-provoking and stimulating presentations. My name is Sala Panapasa. I'm a researcher at the University of Michigan Institute for Social Research, but my research focuses on Pacific Islander populations, and I'm very interested in investigating and certainly expanding some of the work in this population and addressing the diabetes and obesity problem. And I would like to, my question is related and sort of twofold. And I would like to follow up on a statement you made, Dr. Samuel-Hodge, about the challenge and difficulty of improving outcomes when working with morbidly obese, if I may, individuals. And in that situation, when the dyad is both morbidly obese and the challenges, I'm glad to see that there was improvement in the outcome in terms of weight loss on both the a person with type 2 diabetes and their support or caregiving support person in the study. But I'm thinking of implications and, what are the challenges that if you could elaborate on some of the challenges and difficulty, is it when working with this sort of the segment of the population, because that is certainly an issue I face with our Pacific Islander population, where the prevalence and proportion that is morbidly obese, that is with a BMI of 35 and over, is very high. And whether there is a selectivity bias in our work, because in terms of both the huge benefits and being able to keep them motivated and true to the program, whether it's DPP or DSME. So I just wanted to offer that. And and I noticed the presentation focused around food and lifestyle change, around nutrition, but physical activity is an equally important function that, so I feel I got multiple questions, but the most important question for me is the application when working with participants who are, who have a BMI of 35 and above.
Right. Really good question. So I will just begin by saying standard behavioral weight loss interventions don't necessarily work especially well for people with BMIs in the 40s, like class 3 obesity. And that's known. One of the things, going back, standard behavioral weight loss intervention, obviously, if you're going to get to that weight loss outcome, it's not just diet, but there's a physical activity component. We don't really mention it much, but it is there, where the recommendations for physical activity are around, 200 to 300 minutes a week. So it's high. And we, of course, in our interventions, we promote both the dietary changes and physical activity changes. But one of the things that we know with populations with like that class 3 obesity, it's not so much that the dietary issues are much different from those who are not in class 3, but the movement is really drastically removed because of body size. It's mechanically more difficult to move. And so their physical activity levels are quite low. We looked at the African American women in our Heart Healthy Lenore study, which Alice mentioned earlier, and we looked at differences in diet and physical activity behaviors by the class 3 versus the non-class 3. And what we found was the dietary issues were pretty similar, but the physical activity was drastically lower because it's painful to move, it's hard to move, and even moving in outdoor spaces, it just produces a lot of anxiety. So there are all of these issues related to just moving your body. So that has implications for actual weight loss. Current standard behavioral weight loss interventions don't address that because that's not the majority. It just doesn't. And so if you're going to really focus on that population, you really have to start with talking to them about what those issues are, how they feel about certain things in terms of moving their body and eating. And a lot of their issues are coping stress related in terms of behavioral, even movement might be influenced by the way they cope with stressors. And so as we looked at that population of African American women, we said, you know, for this population with class 3, we might need to redesign, you know, really come to their come to look at weight management differently for that population, because their needs are different. And I think a lot more time needs to be spent on that. But it really starts with conversations with those people who live with a body size that fits into that category, so that they can tell you what would make sense for them. But I think one of the biggest issues is movement. And one of the recommendations we made in our paper is that we need to involve physical therapists in the care of people with class 3, because they can show them how to move with that body size. Because, I mean, I can tell you one of the comments we had was that people who are as, you know, that class 3 size, they have a fear of falling. They won't even sit on a stationary bike because they're fearful that something bad might happen. So there are a whole slew of issues that we don't even think about that need to be addressed for that population. And you're not going to find it in the research out there that really doesn't specifically target that population.
Thank you very much.
I dropped a couple names in the chat who work with Marshallese, and it's only one C for McAlfish. Got that wrong.
Thank you. Appreciate that. Yes, I received them.
That's a really, really good question. All right.
The Marshallese are particularly complicated by the fact that they had the nuclear testing that went on there.
I
And
know.
that
I
impact.
know.
So it's really a unique population.
We gave them our worst food.
Right.
And even college food.
I've been focusing primarily on Samoans, Tongans, other Pacific Islanders, and sadly, the recent Lancet article on obesity trends in the world has the 7 of the Pacific Island countries as the leading countries that are the most obese. So that pattern is consistent with what we're seeing among Pacific Islander migrants and immigrants here in the US. And a very sad recent statistic in Fiji, they're conducting up to 3 amputees every day. Oof. And dialysis centers are operating 24/7. So
yeah.
But thank you. Appreciate it.
Yeah.
Just pausing to see if there are any lingering questions. I was going to say burning questions, but even questions that are not so burning, right?
I just have a comment.
Yes.
This is very inspiring work. Like, I feel like I can come from this, hearing both talks, having some real concrete ideas of what I'm in the Bronx of what we could do in our population and how we could make it really accessible to them. So I just really want to thank you. This was really, really helpful.
You're welcome.
And it was really nice to have the history and then the current. So I really like the two of them together. Thank you so much for your creative and energy needed work.
Oh yeah. You're welcome.
We've done the roadshow before. I heard some variation of it.
And Carmen, congratulations again on that new project and the funding for that. We look forward to hearing more about that in the coming months.
Oh yeah. I'm looking forward to learning new things as I left from the academy. Yay! It should be fun.
Bittersweet for those of us still here.
Yeah.
So.
We'll let the
Well,
young ones
thank you.
take over.
Yeah. Well, thank you both so much for today. I mean, this was so enlightening and inspiring, and I echo Jamie's sentiments about it was so nice to kind of watch the evolution of the work. And so we really appreciate you all being intentional about how you arrange this talk today. So thank you for that. And thank you to all of the participants. We appreciate you being here. My hope is that wherever you are, there's probably nice weather. That's my hope. And so thank you for stepping away from the nice weather for a couple of hours just to hang out with us and learn about this inspiring work.
Thanks
So
for the
with that,
invitation.
yeah. So with that, I think we can go ahead and again thank our participants. Thank you so much, Dr. Ammerman. Thank you so much, Dr. Samuel-Hodge. And we will go ahead and let people go and enjoy a couple of extra minutes in their day.
Take care.
Thank you.
Thank you, everyone.